We're going to talk about Chapter 13 today, as well as Chapters 43, 44, and 45 in the ATI MedSearch book. Chapter 13 discusses fluid and electrolytes. Maintaining fluid and electrolyte balance is a dynamic process, which is absolutely critical for life. An imbalance in either fluid or electrolytes, or both, can be life-threatening. We can see an imbalance with many disorders, such as heart failure, diabetes, renal failure, liver disease. These, as well as other disorders, can create fluid and electrolyte imbalances in the body and lead to life-threatening complications. But we don't have to be sick to suffer from fluid and electrolyte imbalances. Excessive exercise, exposure to high environmental temperatures, inadequate intake of either fluid or electrolytes or both can also create an imbalance in the body. There's an increased rise in the number of patients today that are admitted to the hospitals for dehydration, fatigue, and heat stroke. Most people know perfectly well that water is the way to go, but up to 75% of all Americans fall short of the 10 daily cups of water that is recommended by the Institute of Medicine. As a result, this means that most people in the United States are functioning in a chronic state of dehydration. As you remember from Patho and 5th semester, 60% of our bodies is composed of water on average. We know that percentage can vary based on gender, age, but that's the average percentage of water in most Americans. 75% of our muscles is composed of water, and 85% of our brains is composed of fluid. Today, Americans are buying much more soda than they are water. They're consuming far more soda than water. Most people think that if they start to get a little weak or if they have a headache, they need to eat something. But most often, these can be clinical manifestations of a lack of water intake. We know that water is necessary for the body to digest and absorb vitamins and nutrients. It's also key to proper digestion. It detoxifies the liver and kidneys and carries waste. If our urine becomes darkly colored, this likely means that we are dehydrated. As you know, the urine should be light straw colored if we're taking in enough fluid. Over time, failure to drink enough fluid can contribute to an array of medical complications: fatigue, joint pain, weight gain, headaches, ulcers, high blood pressure, and kidney disease, to name a few, can occur as a result of not drinking enough water. In addition, much of our fluid intake can itself have deleterious effects on our health. And what I mean by this is a lot of people have turned to caffeinated beverages. Caffeinated beverages can increase heart rate, can increase blood pressure. They promote a diuretic effect on the kidney, and obviously will, as a result, contribute to signs and symptoms and diseases that can occur related to inadequate water intake. For those who cannot stand the taste of water, some of our patients say, I just don't like water. There's a variety of fruits and vegetables that we as nurses can recommend that can help maintain normal fluid balance. So as you can see, fluid and electrolyte balance is very, very important. And a change in a slight percentage difference or Milliequivalent difference with electrolytes can lead to serious effects. Throughout your nursing career, you will see every day patients who are in imbalance between fluid, electrolytes, or both. As we go through this lecture, we're looking more and more at the medical and nursing interventions that we would do for patients who have a variety of fluid, electrolyte, and acid-base disorders. So here are some review objectives that you should be able to answer based on the PowerPoints and lecture that you all sat through in pathophysiology. And remember that fluid, electrolyte, and acid-base chapter was the big chapter 4. So you need to review that PowerPoint, as well as the PowerPoint that we discussed in the summer in 5th semester on fluid and electrolytes. I will be going over some of that material as I cover these slides, and if you have questions, you can always ask them in class. The Lab to Know sheet that you all received in Patho, and we continued to use it in 5th semester, will be our basis for normal lab values in the fluid and electrolyte acid-base chapter. So look at these objectives and make sure that you can answer them based on the previous 2 semester lectures on fluid and electrolyte acid-base imbalance. So as you remember, we have 2 major fluid compartments, right? We have the intracellular fluid compartment. How much fluid is there? Right, 28 liters. And that's the major fluid compartment that contains the most amount of fluid in the body. Then we have the extracellular fluid compartment. And as you remember, there's approximately 14 liters of fluid in the extracellular fluid compartment. We've talked about the extracellular fluid compartment being composed of the intravascular and interstitial compartments. And now we need to add that third one, and that is transcellular, fluid in the cell itself. The intravascular fluid compartment literally contains 6 liters of fluid. Now, 3 liters is plasma. So when we talked in the past about 3 liters of fluid being contained in the intravascular space, that is absolutely true in the form of plasma. The other 3 liters in the intravascular space is composed of the blood cells, red, white, and platelets. So total, there's approximately 6 liters of volume in the intravascular space. 3 liters of plasma, 3 liters of blood cell. In the interstitial space, again, we learned that there is approximately 11 liters. And if you remember, we've said that this is the fluid compartment in the ECF that contains the most amount of fluid. And now we have the transcellular fluid compartment. The transcellular fluid compartment is fluid that's located in a variety of spaces, such as cerebrospinal fluid would be considered transcellular fluid compartment, synovial fluid in the joint, and again the transcellular fluid compartment contains about 1 liter of fluid. How do we know which compartment that fluid has been lost from? Basically, we're going to assess 4 factors. We're going to check circulatory clinical manifestations, neurological clinical manifestations. We're going to do a physical exam, and we're going to assess lab. Those 4 factors will give us a cue as to which fluid compartment has the imbalance. We also remember that fluid's constantly moving between the compartments in order to maintain equilibrium. Fluid may be lost from the body, or it may be unavailable to the body for use. It could be lost into a space where we cannot retrieve it. And if you remember, that is called third spacing. Alright, as you can see from this slide, we have two major fluid compartments, of which we've already discussed previously. We have the intracellular fluid compartment, and remember, this is all the fluid in our cells. It represents the largest fluid compartment of the body. And how much fluid is in our intracellular fluid compartment? Right, 28 liters. And then we have the extracellular fluid compartment. It's made up of the intravascular fluid compartment. And how much fluid is in the intravascular fluid compartment? 3 liters. But now you need to remember we have an additional 3 liters in the intravascular fluid compartment. And that additional 3 liters is made up of blood cells. Right? Our red, white, and platelets. So combined, we have 6 liters, but 3 liters is actually fluid per se. It's plasma. Then we have the interstitial fluid compartment. And remember, this is fluid in the tissue. How much was there? Right, 11 liters. And then we need to add that third one, the transcellular fluid compartment. The transcellular fluid compartment Alright guys, as you can see from this slide, we have two major fluid compartments. And as you remember, the greatest fluid compartment is the intracellular fluid compartment. And this contains how much fluid? Right, about 28 liters of fluid is contained in the intracellular fluid compartment. This is fluid in all of our cells. Then we have the extracellular fluid compartment. And as you remember, it's made up of the intravascular fluid compartment. How much fluid? 3 liters. But you also need to remember we have an additional 3 liters in the intravascular fluid compartment, and that additional 3 liters is made up of our red, white, and platelet cells. But when we're talking about volume per se, fluid volume, we have 3 liters of plasma fluid volume in the intravascular space. Then we have the interstitial fluid compartment, and as you remember, this is all the fluid in our tissue, accounting for about 11 liters. And remember, this fluid compartment contains the greatest percentage of fluid in the ECF. And then we need to add that third one, transcellular fluid compartment. So as you remember, electrolytes are active chemicals that contain an electrical charge, whether it be a positive, a cation, or negative, an anion. And as you can see on this slide, we have major cations such as sodium and potassium, and major anions such as chloride and bicarb. Also on page 239, table 13.1, it indicates the anions and the cations and their concentrations in the extracellular fluid compartment as well as the intracellular fluid compartment. We know that a change in these cations and anions can lead to imbalances in the body and specific clinical manifestations that may be associated with them, such as too much sodium. We can have a change in volume where our volume would increase, and we could have signs of hypervolemia and vice versa with low sodium, hypovolemia. And we'll talk about this later on. As you remember, fluid balance as well as electrolyte balance is governed by a number of factors. One of the primary factors in the regulating fluid balance is filtration. And that filtration, we're talking about the pressures in the capillary bed. We know that the primary factor that favors filtration, the movement of fluid out of the capillary bed, is the arterial hydrostatic pressure. And the primary pressure that opposes fluid out of the capillary bed is the capillary colloid oncotic pressure. Fluid is moved out of the capillary bed on the arterial side and brought back into the capillary bed on the venous side because the colloid oncotic pressure is greater on the venous side. Another factor that regulates balance is osmosis, where we see a movement of solutes from an area of low concentration to an area of higher concentration. Diffusion, solutes move from an area of higher concentration to one of lower concentration. And then active transport. is the fourth factor in the regulation of fluid and solute balance. That fourth factor from the previous slide was active transport. And remember, active transport involves a pump. And that pump is moving fluid solutes from an area of lower concentration to one of higher concentration. So it's moving against a concentration gradient. The primary example of that active transport factor that helps maintain balance is a sodium-potassium pump. And remember, that sodium-potassium pump that's located on the cell membrane requires energy, a type of gas, for it to work. And that energy, or that gas, is oxygen and glucose. And remember, that pump is pumping sodium out of the cell and potassium into the cell. So as you realize, if that pump is not getting its fuel, such as low glucose or low oxygen, sodium is going to accumulate in the cell, and the cell is going to swell. And potassium will accumulate in the ECF, and we can have dysrhythmias as a result of that hyperkalemia. Eventually the cell will rupture because that excess sodium is attracting water, and the cell can only expand so much before it ruptures. So we will have cell death. So as you remember, we take in fluid from a variety of sources. You can go back and look at the amount of fluid we take in from a variety of sources that we discussed in 4th and 5th semester. But don't forget the fluid taken in intrally, nasogastric tube feedings, fluid that is taken in parenterally, IV solutions, also are going to count as part of our total intake in our patient. And then we have a variety of ways we lose fluid. Again, you can review the total amount of volume that is lost from these areas: kidney, skin, respiratory tract, stool, etc., and which ones are considered sensible and which ones are considered insensible fluid loss routes. Alright guys, this pathoflow sheet basically we've talked about in pathophysiology, but it's just a different diagrammatical representation of what happens when we have loss of volume. And remember, volume loss can be internal or external, and or a gain in osmolality. And remember, when we're talking about osmolality, we're talking about the solute per solvent concentration in the ECF. I can have an increase in osmolality because I gain solutes such as sodium or glucose, or I can have an increase in osmolality because I've lost water. Regardless, whether it be a loss of blood volume or an increase in osmolality, we have the thirst center and the hypothalamus activated. And remember, not everybody can respond to the thirst mechanisms, such as people with Alzheimer's disease, infants, people who are comatose, etc. That loss of volume leads to a decrease in arterial blood pressure, which stimulates the baroreceptors on the carotid arteries and the aortic arch, and we have activation of the sympathetic nervous system, and a decrease in blood perfusion to the kidneys. So remember, when we're talking about perfusion of the kidneys, we're talking about the glomerular filtration rate. We've already said that. The kidneys are not considered a vital organ. Alright, so when we've lost volume, per se, or an increase in osmolality, we're going to try to get volume to other areas of the body, and not necessarily the kidneys. So that decreased GFR, decreased blood flow to the kidneys, we have the release of renin. The renin-aldosterone angiotensin mechanism is activated. And it is that aldosterone, the end result of the renin mechanism, that will stimulate the kidneys to retain sodium chloride and water. So we'll have a decreased excretion of sodium chloride and water from the kidneys. Remember, aldosterone also stimulates the kidneys to get rid of potassium, so potassium levels will fall. If we retain sodium chloride and thus water, we're going to have an increase in our pressure, and circulating volume will be restored, as well as osmolality, if that is the cause. The other factor that happens with a decrease in volume and or increase in osmolality is ADH. And remember, ADH is primarily stimulated, or ADH is released from the posterior pituitary, primarily related to a change in volume. All right, remember, I can have that change in volume because I've either lost it, or I can have that change in volume because I have too much solute. So ADH tells the kidney to retain water, and urinary output would decline as well. So the renin-aldosterone angiotensin mechanism, as well as ADH, are physiological events that can help us restore blood volume as well as osmolality. Alright guys, as you can see from this flow diagram, we've already talked about this previously in other courses, but let's review what happens when I have a loss of volume, and that loss of volume can be internal or external, and or a gain in osmolality. Remember, osmolality, we're talking about solute per solvent concentration. And I can have an increase in osmolality either because I gained too much solute or I've lost solvent. Regardless of either factor, we have activation of the thirst mechanism. And remember, not everybody can respond to the thirst mechanism. That loss of volume decreases blood pressure, and we have activation of the sympathetic nervous system. We also have decreased blood flow to the kidney. And when we're talking about blood flow to the kidney, we're talking about glomerular filtration rate, right? When the kidney suffers from a decreased GFR, we have activation of the renin-angiotensin-aldosterone mechanism. And the end result of that, if you remember, is the secretion of the aldosterone from the adrenal cortex. And aldosterone stimulates that kidney to retain sodium chloride and indirectly water and excrete potassium. By retaining that sodium chloride and indirectly water, volume may be restored, as well as osmolality, particularly if it was increased due to a loss of water. The other factor that comes into play when we have a decreased blood volume or an increase in osmolality is production of ADH. ADH, as you remember, is from the posterior pituitary, and it does one role. It tells the kidney to do what? That's to retain water. Again, by retaining water, blood volume and serum osmolality may be restored if this is due to a volume problem. Alright guys, this flow sheet we've already talked about previously, but let's look at it one more time. When we have a loss of blood volume or an increase in osmolality, and remember when we're talking about an increase in osmolality, we can have too much solute or we've lost solvent, and the serum osmolality levels rise. We've already discussed normal serum osmolality values in pathophysiology. Regardless whether it's a loss of blood volume or an increase in osmolality, we have activation of the thirst mechanism. And as you remember, not everybody can respond to the thirst mechanism. The loss of blood volume and increase in osmolality will decrease arterial blood pressure, which in turn stimulates the sympathetic nervous system. And in turn, we have decreased renal perfusion. When the kidneys suffer from decreased volume, remember, we're talking about GFR. Glomerular filtration rate refers to the perfusion of kidneys, okay, by blood volume. When the kidney suffers from decreased perfusion, we have the activation of the renin-angiotensin-aldosterone mechanism. The end result, the aldosterone stimulates the kidney to retain sodium chloride and indirectly water. And remember, it also stimulates the kidney to excrete potassium. By retaining sodium chloride and indirectly water, blood volume and osmolality may be restored. The other factor that comes into play with decreased volume or an increase in osmolality is the production of ADH. ADH from the posterior pituitary, as you remember, tells the kidney to do one thing, and that's to retain water. So again, this may be a helpful mechanism when blood volume is reduced or we have an increase in serum osmolality, primarily due to a loss of solvent. Alright guys, this slide represents the role of ANF. ANF may also be referred to as AMP, atrionatriuretic peptide, atrionatriuretic factor. What stimulates the production of this hormone? An increase in sodium chloride concentration, an increase in blood pressure, an increase in blood volume. When this happens, the right atria is stretched, and the right atrial cells release ANF. ANF suppresses the renin mechanism. ANF suppresses the production of aldosterone. ANF suppresses the production of ADH. ANF increases GFR. As we increase perfusion of the kidney, we're going to make more urine, and we're going to excrete more water. As a result, blood volume is going to be reduced. Not only blood volume is reduced, arterial blood pressure will be reduced. Heart rate, CVP, cardiac output, and preload will all be reduced by ANF. Alright guys, the natriuretic peptides. The natriuretic peptides, there are 4 of them. I'm going to mention the 2 most abundant ones, and that's ANF, atrial natriuretic factor, also called atrial natriuretic peptide. The second one is brain natriuretic factor. These are natriuretic peptides that affect fluid volume and cardiovascular function through excretion of sodium and direct vasodilation and opposition of the renin mechanism. ANF is secreted from the right atrium when sodium chloride concentration, blood volume, blood pressure are elevated. BNP is released from the brain as well as the ventricles when those factors again exist. What happens as a result of these natriuretic peptides? The renin mechanism is suppressed, aldosterone release is suppressed, and ADH release is also suppressed. BNP and ANF increase GFR, blood flow to kidneys, and thus we have excretion of sodium chloride and water. So the rate of urine production increases as well as the rate of water excretion. In turn, blood volume is going to be reduced. CVP, cardiac output, arterial blood pressure, preload, and heart rate will all fall as a result of a decrease in blood volume from the natriuretic factors. Alright guys, I'm going to talk about the natriuretic peptides. The 2 most abundant ones are ANF, atrial natriuretic factor, and BNP, brain natriuretic peptide. ANF is produced from the right atrium. BNP is produced from the ventricles of the heart as well as the brain. Both of these will increase sodium excretion, they'll cause vasodilation, and they oppose the renin angiotensin aldosterone mechanism. What would activate the release of these 2 predominant natriuretic hormones? An increase in sodium chloride concentration, an increase in blood pressure, and an increase in blood volume. These natriuretic peptides will suppress the renin mechanism, will suppress the production of aldosterone, will suppress the release of ADH, and they will increase GFR. If we increase blood flow to the kidneys, then we're going to have more sodium chloride and water excretion. In turn, blood volume, CVP, cardiac output, arterial blood pressure, preload, and heart rate will all decline. When we're talking about alterations in fluid volume balance, fluid volume deficit is a common problem that we encounter today. In fluid volume deficit, the loss of extracellular fluid exceeds the ratio of water intake. Electrolytes are lost in the same proportion as they exist in normal body fluid, so we're going to see no change in the lab. Dehydration, we're talking about a greater loss of water and an increase in sodium chloride levels. Causes of dehydration may be such things as vomiting, diarrhea, GI suctioning, excessive diaphoresis, decreased intake of water, diabetes insipidus, adrenal insufficiency, osmotic diuresis, hemorrhage, coma, third spacing can all be causes of dehydration. Remember, in dehydration, we have a greater loss of water and an increase in sodium chloride levels. Clinical manifestations of fluid volume deficit or hypovolemia are on page 246 of chapter 13 and include rapid weight loss, decreased skin turgor, oliguria, postural hypotension, and you all know the definition for postural hypotension. They can also include tachycardia, cool, clammy skin, sluggishness, muscle weakness, muscle cramps. The BUN is going to be elevated. BUN definitely could be elevated when we have decreased volume to the kidney. We have increased hematocrit with fluid volume deficit, and serum electrolyte changes may occur. Medical management for fluid volume deficit, ideally oral fluids, water, or a rehydrated solution like hydrolyte. If the patient's unable to take in adequate amounts of water, then IV solutions such as normal saline and Ringer's lactate may be used. Clinical manifestations of fluid volume deficit or hypovolemia are on page 246 of chapter 13 and include a rapid weight loss, decreased skin turgor, oliguria, concentrated urine. The specific gravity would increase, postural hypotension, and you all know the definition for postural hypotension, tachycardia, cool clammy skin, muscle weakness, muscle cramps may be noted with fluid volume deficit. Potassium, sodium levels may or may not change depending on the cause. The BUN is going to be elevated in relation to the plasma creatinine. And we're going to see a hemoconcentration in the intravascular space, so the hematocrit will also be elevated. Medical management, ideally we'd like the patient to consume the fluid orally, and that could be in the form of water or a rehydration solution like rehydrolyte. If they're unable to consume adequate amounts of fluid, then we're going to look at IV solutions such as normal saline or Ringer's lactate. I'm going to talk more in depth about this slide in class, but right now nursing management for fluid volume deficit would include such things as monitoring the INO, the daily weight, and that daily weight should be obtained in the morning, monitoring vital signs, monitoring skin and tongue turgor, urinary output, mental status, instituting measures to minimize fluid loss, like giving antidiarrheals, antiemetics that have been prescribed by the doctor, providing oral care, increasing the intake of oral fluids, administration of parenteral fluids that might have been ordered by the physician, as well as perhaps a fluid challenge test. The preferred route of volume replacement would be oral, but most patients who have fluid volume deficit cannot consume enough oral fluids to replace the amount of fluid that they've lost, so we're going to turn to IVs. We've talked about IVs somewhat already in the 5th semester, but we're going to look at them even further here. The isotonic IV solutions are 0.9% normal saline, lactated Ringer's, and D5W. The isotonic solutions contain approximately the same osmolality as the ECF. For example, 0.9% solution has an osmolality of 308 milliosmoles, which approximates the ECF. So these isotonic solutions are used to replace ECF volume and expand ECF volume. We want to use them cautiously in people who have hypertension as well as heart failure because they can worsen both of those. D5W, which probably is the least of the three that's used for ECF volume replacement. In its pure form, it's considered isotonic, but once it enters the body's going to metabolize the dextrose and leave the body with water. And that water primarily is going to flow into the cell. So we're going to be very careful in giving this solution to someone who's at risk for or has increased intracranial pressure, because it sure can increase it even more so. Long-term use can cause hyperglycemia. And if the patient has diabetes, obviously it can worsen the diabetes. It's used primarily to supply water and correct an increase in serum osmolality that is due to water loss. 0.9% normal saline probably is the most common isotonic fluid that's used for volume replacement and volume maintenance. Again, it contains sodium and chloride, as well as water. This is the one, as you know, that's used for blood transfusions. Lactated Ringer's is considered a volume expander. In addition to sodium chloride, it contains potassium and calcium. It definitely can be used to correct dehydration, as well as sodium loss and replace GI losses. The lactate is converted to bicarb in the liver. So if someone has liver disease, generally we don't use lactated ringers because the liver cannot break down the lactate. We don't give this solution to people who have kidney disease because lactated ringers contains potassium, and potassium levels will rise or elevate even worse if we give lactated ringers to that patient with kidney disease. When we're talking about fluid volume excess, we're talking about hypervolemia. We have fluid overload. There are a number of causes of hypervolemia, and perhaps the number one cause is excess sodium intake. African Americans, the elderly, have a higher risk for hypervolemia because of the inability to regulate sodium. Other causes of fluid volume excess may include heart failure, steroid therapy, because steroids, and particularly long-term steroid therapy, steroids have very similar properties to that of aldosterone, kidney failure, cirrhosis of the liver, excess administration of IV solutions such as 0.9% normal saline and LR may be causes of fluid volume excess. Clinical manifestations may include edema, and again, the edema is related to the increase in venous hydrostatic pressure, can include hypertension because of the increased arterial pressure, widened pulse pressure, an increase in CVP, an increase in weight, urinary output, shortness of breath, and wheezing, as well as JVD may be signs of fluid volume excess. Another example of fluid volume imbalance is fluid volume excess or hypervolemia. We're talking about fluid overload. There are a number of risk factors and causes of fluid volume excess. The number one risk factor or cause is excess sodium intake. We've already talked about this being the number one factor in the United States in people who are of elderly and African American descent. Other causes may be prolonged steroid use because steroids contain very similar properties to aldosterone, liver failure, kidney failure, heart failure, SIADH, where ADH levels are very high, perhaps due to trauma to the posterior pituitary. We can also have elevated ADH levels as a manifestation of certain types of cancers, such as lung cancers. Fluid overload may also be related to excess administration of IVs that contain sodium, such as 0.9% normal saline and lactated ringers. There are the clinical manifestations of fluid volume excess. Again, you remember volume governs pressure, so we'll see an increase in hydrostatic and venous pressures, leading to hypertension and edema. Remember, the first place for edema varies in a patient who is bedridden versus one who is ambulatory. We should reflect on the areas that are affected in both of those patients initially. Other manifestations would be JVD, tachycardia, crackles, rails, increased pulse pressure, increased CVP, increased weight, increased urinary output, shortness of breath can all be clinical manifestations associated with fluid volume excess. Laboratory-wise, BUN and hematocrit will be decreased because of hemodilution. Sodium levels may be decreased if the problem is related to kidney failure or SIADH. Sodium levels may be increased if the problem is related to excess sodium intake, for example. Another fluid imbalance that we commonly see today is fluid volume excess or hypervolemia. We're talking about fluid overload. There are a number of risk factors or causes of hypervolemia today in the United States. The number one risk factor or cause is excess sodium intake. We know this is a primary risk factor for hypervolemia in the elderly because of the efficiency of the kidney being less apt to adapt to high sodium levels, as well as in the African Americans. Excess steroid therapy, because steroids contain very similar properties to aldosterone. is a risk factor for hypervolemia. SIADH, too much ADH, perhaps due to trauma, head trauma, where the posterior pituitary is producing ADH. We can also see high ADH levels as a clinical manifestation of certain types of cancers, such as lung cancers. Excess administration of IV solutions that contain sodium chloride, such as 0.9% normal saline, may be a risk factor for hypervolemia. Kidney failure, liver failure, heart failure can be causes or risk factors. Clinical manifestations, again, we have excess volume. We're going to see hypertension. Edema. And remember, the edema is first going to develop in the most dependent parts of the body, and those dependent parts are different from one who's on bed rest versus one who is ambulatory. JVD, increased pulse pressure, increased CVP, increased weight, increased urinary output, shortness of breath, rales, crackles, may all be clinical manifestations of hypervolemia. The BUN and the hematocrit will decline because the plasma volume is hemodiluted. Sodium levels may be low if the problem is related to water retention only, such as in SIADH. Sodium levels may be elevated if the problem is related to excess intake as well as kidney. Another fluid imbalance that we commonly see today is fluid volume excess or hypervolemia. We're talking about fluid overload. There are a number of risk factors or causes of fluid volume excess. The number one cause in the United States today is excess sodium intake. We know as we age, the kidneys are less efficient in adapting to sodium levels, thus sodium levels tend to rise. We also know that African Americans have a higher risk of hypervolemia due to, again, less efficiency of the kidneys to regulate sodium chloride levels. Prolonged steroid use. Steroids contain very similar properties to that of aldosterone, may be a cause of hypervolemia. Too much ADH from the posterior pituitary, perhaps related to head trauma or cranial surgery. We can also see high levels of ADH as a clinical manifestation of certain types of cancers, such as lung cancer. Heart failure. Excess administration of IV solutions, such as 0.9% normal saline, can cause hypervolemia. Kidney failure, liver failure, too much aldosterone can all be risk factors for fluid volume excess. The clinical manifestations are directly related to that excess volume, so we see increased blood pressure, hypertension, increased pulse pressure, increased CVP, edema. And remember, the edema is related to increased venous hydrostatic pressure on the capillary side and that the edema is going to first develop in the most distal parts of the body. Remember, the distal part of the body is different on someone who's on bed rest versus someone who is ambulatory. Increased jugular vein distension, increased weight, urinary output, shortness of breath, rales, crackles may be additional clinical manifestations. BUN and creatinine levels decline because of the hemodilution. Sodium levels may be elevated, particularly if it's related to excess intake or renal failure. Sodium levels may be hypodilutional. They may be falsely low, particularly if the problem is related to SIADH, where we're retaining more water, which dilutes the sodium. I'm going to talk more about this slide in class, but medical management is directed at finding and treating the cause of the hypervolemia, restricting fluids and sodium, and administration of diuretics. The three classes of diuretics that are often used are the thiazide diuretics, the loop diuretics, and the potassium-sparing diuretics. Which class of diuretic is generally prescribed depends upon three factors: the severity of hypervolemia, the degree of renal impairment, and the potency of the diuretic. Nursing management includes monitoring the INO, daily weights. Keep in mind, for every liter of fluid that we gain 1 kilo or 2.2 pounds. Assessing lung sounds, particularly at the bases of the lungs where fluid will accumulate first. Monitoring therapeutic effects of the medications, such as the diuretics. Promoting adherence to fluid restrictions. Teaching the patient about foods that are high as well as low in sodium. Promoting bed rest. Administering good skin care. Positioning and turning. I'm going to talk about this slide more in depth in class, but the medical management is directed at finding and treating the cause of the hypervolemia, restricting fluids and sodium, and administering diuretics. The three classes of diuretics that may be prescribed are the thiazide diuretics, the loop diuretics, and the potassium-sparing diuretics. Which class is prescribed for the patient depends upon three factors: the severity of the hypervolemia, the degree of renal impairment, and the potency of the diuretic. Nursing management includes intake and output, assessing daily morning weights. Remember, for every liter of fluid that I gain 1 kilo. Assessing lung sounds, particularly at the bases. Monitoring the response to medications. Promoting adherence to fluid restrictions. Patient teaching, particularly of foods that are high and low in sodium. Placing in a semi-thalus position the patients who are orthopnic, providing good skin care. I'm going to talk much more about this slide in class, but the medical management for hypervolemia is directed at finding and treating the cause of the hypervolemia, restricting fluids and sodium, and administering diuretics. There are three classes of diuretics that may be prescribed: the thiazide diuretics, the loop diuretics, and potassium-sparing diuretics. Which class will be prescribed is dependent on three factors: the severity of the hypervolemia, the degree of renal impairment, and the potency of the diuretic. Nursing management, we're going to monitor the I&O. We're going to assess daily weights in the morning. Remember, for every liter of fluid that is gained or lost, I gain a kilogram. Assess lung sounds. Remember, we're going to listen for crackles, rails at the bases of the lungs. Nursing management also includes monitoring responses to the medications, to the diuretics. Again, we don't want a rebound effect of the production of ADH if we've lost too much volume, so I&O is very, very important. We want to promote adherence to fluid restrictions as well as sodium restrictions. We want to teach the patient foods that are high as well as low in sodium. We want to promote rest, provide good skin care. Assess edema, the degree of edema, the location of the edema. Remember, edema can rank from 0 to 4 plus. At 4 plus edema, remember the millimeter depth would be 8 millimeters. All right, hyponatremia. We're talking about a serum sodium level of less than 135 and a decrease in serum osmolality. True causes of hyponatremia include vomiting, diarrhea, excessive diaphoresis, excessive diuresis, as well as Addison's disease. Sodium levels may be low because they are diluted with excess water. So water intoxication and SIADH may also be causes of hyponatremia. Keep in mind, though, the hyponatremia is dilutional. Manifestations of true low sodium include port skin turgor, dry mucosa, decreased salivation, decreased blood pressure, tachycardia, nausea, neurological changes such as cephalgia, seizures, and decreased level of consciousness. Keep in mind, as serum sodium levels fall, the attraction for water declines and water moves into the cells, particularly those of the brain. Medical management for true sodium loss, sodium replacement, orally, IV, or NG. IV, such as lactated ringers or 0.9% normal saline, may be given to replace sodium. The nurse must be careful not to administer these IV solutions too rapidly because demyelination may occur, which involves destruction of the myelin sheath. Destruction of the myelin sheath will lead to decreased nerve impulse transmission and may be manifested by paresthesia, decreased sensation, decreased cognition, Water restriction may be employed if sodium levels are low due to excess water. Nursing management, obviously assess clients who are at high risk for hyponatremia. Again, those with vomiting, diarrhea, excessive diaphoresis, excessive urination. Promote dietary sodium intake, such as the use of beef broth, tomato juice. Promote fluid intake. Monitor INO, daily weights. Assess neurological function. Again, confusion may be an early sign of hyponatremia and may be overlooked in the elderly because it may be considered just a normal sign of aging. Hypernatremia, serum sodium level greater than 145, as well as an increase in serum osmolality. Causes of hypernatremia: patients who are comatose, patients who are confused, such as those with Alzheimer's, who may be unable to drink water, excess water loss, excess sodium administration, diabetes insipidus, where there's a lack of ADH and an increase in water loss, heat stroke, the administration of 3% hypertonic IV solutions, administration of enteral tube feedings containing sodium may be causes of hypernatremia. Hypernatremia may be manifested as thirst, elevated temperature, swollen tongue, sticky mucosa, neurological symptoms such as restlessness, tachycardia, and hypertension. Medical management: hypotonic electrolyte solution, 0.3% normal saline or D5W. Sodium levels are reduced gradually to prevent cerebral edema. If sodium levels are reduced too rapidly, water will flow into the cells. Diuretics that promote sodium excretion: the thiazide diuretics, the loop diuretics may also be employed. Vasopressin may be administered for patients who have hypernatremia due to diabetes insipidus. This is a synthetic form of ADH. Nursing management: assess patients who are at higher risk for hypernatremia, such as those who are comatose, those who have Alzheimer's disease. Encourage fluid intake, particularly in those patients who might be confused and not be drinking water adequately throughout the day. Assess for sources of high sodium, such as the use of Alka-Seltzer. Foods that contain high sodium. Offer and encourage fluids to meet the patient needs. Provide sufficient water with tube feedings to prevent hypernatremia. All right, hypernatremia, we're talking about a serum sodium level greater than 145 and a serum osmolality greater than 310. Causes of hypernatremia: comatose patients who are unable to drink, consume fluids. People with Alzheimer's disease may not be drinking fluids in normal amounts. Excessive water loss, such as watery diarrhea. Excessive sodium administration, diabetes insipidus, where we lose more water because of a lack of ADH. Heat stroke, the administration of 3% hypertonic IV solutions, the administration of enteral tube feedings that contain sodium may all be causes of hypernatremia. Manifestations of hypernatremia may include such things as thirst. Remember, not everybody can respond to the thirst mechanism. Elevated temperature, swollen dry tongue, deep furrow of the tongue, sticky mucosa, neurological symptoms such as restlessness, tachycardia, and hypertension. Medical management is focused on reducing sodium levels. Sodium levels are gradually reduced to prevent cerebral edema. If sodium levels are reduced too rapidly, water will flow into the cell. Diuretics that promote sodium excretion, such as thiazide and loop diuretics. The administration of vasopressin, synthetic ADH, for patients who have hypernatremia due to diabetes insipidus. 0.3% normal saline or D5W promotes the excretion of sodium. Nursing management. Assess and prevent hypernatremia in people who are at higher risk, such as those mentioned earlier. Assess for over-the-counter sources of sodium, such as Alka-Seltzer use for indigestion. Offer and encourage fluids to prevent hypernatremia from occurring due to a lack of fluid intake. Provide sufficient water with tube feedings, again to prevent hypernatremia. I'm going to talk right now about potassium imbalances, but before I do, I just want to reiterate some of the things you already know. 98% of total body potassium is found in the cell. 2% of total body potassium is located outside the cell. We know potassium affects muscle groups such as cardiac, skeletal, and smooth muscle. When potassium levels rise, initially activity within these muscle groups increases as well. When potassium levels fall, we have a concomitant fall or decrease within these muscle groups. To maintain normal potassium balance in the ECF as well as the cell, we need an effective sodium-potassium pump. That pump that's found on the cell membrane operates via fuel of oxygen and glucose. If those fuels are lacking to the pump, potassium levels will rise in the ECF and fall within the cell. We know medications can affect potassium levels. We know acid-base imbalances can affect potassium levels, as well as hormones such as aldosterone. 80% of potassium leaves the body via the urine. 20% of daily potassium is lost via the bowel and sweat. Hypokalemia, the primary causes of hypokalemia are related to the GI tract. Vomiting, diarrhea, prolonged gastric suctioning, fistulas may all be causes of hypokalemia. Medications such as the thiazide, the loop diuretics can also be causes. Metabolic or respiratory alkalosis, again because in alkalosis the competition for intracellular space by hydrogen is decreased, so potassium can move in more readily. A lack of intake, chronic use of NSAIDs or steroids can cause hypokalemia, too much insulin, and people who are anorexic are at high risk for hypokalemia. Generally, we do not see manifestations of hypokalemia till the potassium level gets to below 3. The clinical manifestations are most often associated with those muscle groups. I will have skeletal muscle fatigue. I may have dysrhythmias, muscle weakness, muscle cramps, paresthesia, decreased muscle strength, bradycardia associated with hypokalemia. Obviously, the goal is to replenish potassium either via the diet or oral medication or IV. Nursing management, obviously we're going to keep track of people who are at high risk for hypokalemia. Again, those who have prolonged GI suctioning, those who have diarrhea, vomiting. Severe hypokalemia definitely can be life-threatening. Dietary potassium, generally 50 to 100 milliequivalents of potassium per day is required in the adult. There are a number of foods that contain high levels of potassium, such as fruits. Bananas contain 422 milligrams of potassium. Orange juice, a 6-ounce glass of orange juice contains 322 milligrams of potassium. 8 ounces of milk or an 8-ounce yogurt contains 400 milligrams of potassium. An orange is 240 milligrams of potassium. Baked potato with skin, 925 milligrams of potassium. Watermelon is low in potassium, about 85 milligrams. Green beans, a half a cup, it's about 90 milligrams, etc. We said that the adult needs 50 to 100 milliequivalents per day, and that would equate to approximately 4,700 milligrams of potassium per day. So now you can see how many bananas, how much orange juice, etc. Someone would need to take in to maintain that 4,700 milligrams per day. Salt substitute can be a great source for potassium replacement because a teaspoon of salt substitute equals 50 milliequivalents. Generally, we're going to try to replace the lost potassium orally. PO potassium is well absorbed from the GI tract. PO potassium, we're talking about potassium gluconate. This is a seltzer type medication that is generally mixed in water or taken with meals to prevent GI discomfort and oral ulceration. It can cause nausea, vomiting, esophagitis, diarrhea, but the oral route is well absorbed. Potassium is well absorbed, and it is preferred route unless the potassium levels are extremely low, 2 or lower. The doctor then may order potassium chloride IV. Before we give potassium chloride IV, we must ensure that there's adequate urinary output. We need to assess the IV for patency because potassium is very irritating to the veins. Potassium IV is always given via an IV pump. The concentration may vary anywhere from 10 to 40 milliequivalents per 1 liter to a maximum of 200 milliequivalents per day. Potassium is diluted in D5W or normal saline. Again, we need to have a patent IV and ideally a large bore IV. Potassium is never given IM or IV push. During potassium infusion, we need to monitor the urinary output. If the urinary output drops below 20 mils per hour for 2 consecutive hours, the potassium infusion should be stopped because of a risk of hyperkalemia. One other thing I just want to add is that many times we also may see low magnesium with low potassium. They can both go hand in hand. Low magnesium must be treated first before low potassium, because low magnesium potentiates the excretion of potassium from the body. So if the approach was to supplement potassium before we corrected the magnesium level, that supplemental potassium will continue to be lost from the body. If a patient has 50 milliequivalents of KCl and 1 liter of normal saline to be infused over 10 hours, how many milliequivalents will that patient receive per hour? All right, I'm going to talk about potassium imbalances, but before I do, I just want to review a couple facts. 98% of total body potassium is in the cell. 2% is extracellularly. Potassium affects skeletal, cardiac, and smooth muscle. We know when potassium levels are elevated, activity within these muscle groups increase. We know that when potassium levels are low, activity within these muscle groups decrease as well. Potassium levels are regulated by the sodium-potassium pump, that pump found on the cell membrane that requires oxygen and glucose. If that pump is not receiving oxygen and glucose as fuel, potassium levels will rise in the ECF because the pump fails. We know that medications, acid-base imbalances, and aldosterone can all affect potassium. Hypokalemia is the most common electrolyte abnormality that we see in the United States today. There are a variety of causes of hypokalemia. The primary causes of hypokalemia are related to the GI tract: vomiting, diarrhea, prolonged gastric suctioning, fistulas, may be GI causes of hypokalemia. Meds such as thiazide and loop diuretics, insulin, steroids, NSAIDs may also cause hypokalemia. Acid-base imbalances such as alkalosis, because the competition with hydrogen for the intracellular space is reduced. Manifestations of potassium abnormalities generally are not seen until potassium levels are below 3. Manifestations of hypokalemia include such things as fatigue, muscle weakness, constipation, decreased muscle strength, decreased DTRs, muscle cramps, may all be clinical manifestations. Dysrhythmias such as bradycardia or even cardiac and respiratory arrest can occur with severe low levels of potassium. Obviously, the medical management is focused on identifying and treating the cause and replacing the potassium, whether that be orally, via drugs or diet, or parenterally. Nursing management. We want to be aware of those who are at higher risk for hypokalemia, because hypokalemia can definitely be life-threatening. Dietary potassium recommended amounts per day are 50 to 100 milliequivalents per day, or 4,700 milligrams. Fruits high in potassium that we may be encouraging our client to consume when their potassium levels are on the low side include such things as bananas. One banana has 422 milligrams of potassium. Orange juice, a 6-ounce glass, has 322 milligrams of potassium. Milk, 8-ounce glass of milk, 8 ounces of yogurt have 400 milligrams of potassium. An orange is 240. A baked potato with skin has 925. So you can see there are a number of foods that are very high in potassium. Watermelon, a half a cup of green beans are not good sources of potassium because they represent 85 milligrams to 190 milligrams respectively. The patient may be encouraged to use salt substitute. Salt substitute has approximately 50 milliequivalents of potassium per teaspoon. Oral replacement, in addition to foods, may include potassium gluconate. Potassium gluconate is found on page 234 of the Pharm ATI. Potassium gluconate can come in a powder form, and it should be taken with meals or dissolved in 8 ounces of water to prevent GI discomfort, esophagitis, diarrhea, abdominal pain, or even oral ulceration development. We want to teach the patient to take this medication with meals because it's very well absorbed via the GI tract. If the potassium levels are extremely low, 2 or lower, potassium chloride may be prescribed intravenously. Before we give potassium via the parenteral route, we need to make sure the client has adequate urinary output because, again, as you remember, most potassium that is lost from the body is lost via the kidney. We need a patent large bore IV. We need an infusion pump prior to administering IV KCl. IV KCl is always diluted either in normal saline or D5W. The normal range of concentration is 10 to 40 milliequivalents per 100 cc's, 100 milliliters, with a maximum per hour of 200 milliequivalents. If the patient has 50 milliequivalents of KCl in 1 liter of normal saline to be infused over 10 hours, how many milliequivalents will he receive per hour? Is it too much? As potassium is infusing intravenously, again, we need to monitor the urinary output. If the urinary output drops below 20 mils per hour for 2 consecutive hours, the infusion should be stopped and the physician notified. Potassium is never given intramuscularly or IV push. Hyperkalemia occurs very rarely in clients who have normal renal function. Causes of hyperkalemia may include drugs such as the ACE inhibitors, enalapril, lisinopril, the potassium-sparing diuretics, NSAIDs, acute and chronic renal failure, Addison's disease, tissue trauma, the use of stored whole blood, respiratory or metabolic acidosis can all be causes. Today, the most common cause of hyperkalemia is due to medications such as the ACE inhibitors, followed by renal disease. Excess salt substitute can be another cause. The manifestations of hyperkalemia are primarily manifested via the cardiovascular system. We begin to see changes in the EKG complex when potassium levels approach 6 milliequivalents. Dysrhythmias occur when the potassium levels approach 8 milliequivalents. Tachycardia first to bradycardia and then to cardiac arrest. Skeletal muscle weakness, respiratory impairment, paresthesia, anxiety, GI manifestations such as nausea, vomiting, abdominal cramping may all be clinical manifestations associated with hyperkalemia. The medical management obviously is focused on identifying and treating the cause and lowering the potassium levels before we see the cardiac effects. Medical management may include such things as limiting dietary intake of potassium, the use of K-exolate via a enema. K-exolate is a medication that is given via a retention enema. K-electrolyte absorbs or attracts potassium into the GI tract so it can be eliminated via the stool. IV soda bicarb may be a medical intervention if the cause is related to acidosis. IV calcium gluconate. Calcium gluconate blocks the action of potassium on the myocardium. This blocking effect is only temporary, lasting about 30 minutes. Regular insulin can be given to push the potassium into the cell and get it out of the blood temporarily. Hypertonic dextrose IV D10W may be used again to block the effects of potassium and decrease its level. Beta-2 agonists such as albuterol are very effective in blocking potassium, but their use is very controversial because they can cause dysrhythmias and chest pain. Dialysis may also be another treatment. Nursing management, obviously we're going to assess levels and monitor patients who are at high risk for hyperkalemia. Assess for clinical manifestations of hyperkalemia. We may teach the patient dietary restriction, foods to avoid, such as fruits and vegetables. Coffee, tea have about 150 milligrams, anywhere from 110 to 150 milligrams of potassium. Obviously, we want the patient to avoid using salt substitutes. Potassium levels may be falsely elevated if potassium blood draw was done above an IV site where there was potassium in the IV fluid. Potassium-sparing diuretics may cause elevation of potassium and obviously should not be used in patients with hyperkalemia. We should be checking the apical pulse for any signs of cardiac dysrhythmias in respect to a change in heart rate. Okay, hyperkalemia. We're talking about a potassium level greater than 5.0. Hyperkalemia is fairly rare in individuals who have normal kidney function. Most common cause of hyperkalemia today is related to the use of certain drugs, particularly the ACE inhibitors, such as enalapril and lisinopril. Another common cause of hyperkalemia is chronic renal failure. Renal disease decreases the excretion of potassium and can lead to hyperkalemia. Addison's disease, the use of potassium-sparing diuretics, major tissue trauma such as with the MVA, respiratory or metabolic acidosis, excessive administration of stored whole blood, excessive use of salt substitutes may all be causes of hyperkalemia. Keep in mind that potassium chloride that you gave to that patient for hypokalemia may have been infused too rapidly and could also be a cause of hyperkalemia. Obviously, the medical management is focused on identifying the cause and treating the hyperkalemia. Hyperkalemia may be treated via the diet, just by limiting foods high in potassium. K-electrolyte A drug that promotes the absorption of potassium from the GI tract may be used, such as in a retention enema. Electrolyte introduced into the colon via an enema attracts potassium into the GI tract so it can be eliminated via the stool. IV soda bicarb may be given to correct the acidosis that is causing the hyperkalemia. IV calcium gluconate may be given to block the effects of potassium on the myocardium. This effect on the myocardium by IV calcium gluconate is short-lived, approximately 30 minutes. The use of regular insulin and a hypertonic dextrose IV solution such as D10W causes a temporary shift of potassium into the cells. Loop diuretics such as furosemide may be prescribed to lower the potassium levels. Nursing management obviously is assessed for clients who are at high risk for hyperkalemia, assessed for skeletal muscle weakness, dysrhythmias, tachycardia progressing to bradycardia, teaching patients to avoid foods that are high in potassium. Coffee and tea contain anywhere from about 120 to 150 milligrams of potassium. We've already talked about salt substitutes, the percentage of potassium in salt substitutes. If blood that's drawn for a lab test sits for too long, red blood cells begin to break down, and we'll see a false elevated potassium level in that blood draw specimen. So blood draw specimens should be sent immediately to the lab and not allowed to sit for a period of time. As well, drawing blood above an IV site where the IV solution contains potassium may cause a false high potassium level to be reported on the lab results. Nurses should question the use of potassium-sparing diuretics, especially in people who have renal disease. Apical pulse should be assessed regularly so that early signs of tachycardia, which may progress to bradycardia, can be known. Need to assess for GI manifestations of hyperkalemia, such as nausea, vomiting, abdominal cramping, as well as paresthesias, anxiety, and irritability in the patient. Hyperkalemia is much more dangerous than hypokalemia. Even though it occurs more rarely, it is considered more dangerous because of a greater incidence of cardiac arrest.
All right, guys. Hypocalcemia. We're talking about calcium level in the blood below 8.5 milligrams. Definitely hypocalcemia can be life-threatening because of the effects on the respiratory and cardiovascular system. Causes of hypocalcemia. Today, there are probably three primary causes. A lack of intake of calcium, a lack of intake of vitamin D, and the development of chronic renal failure. Other causes may include prolonged bed rest, excessive whole blood.
Testing 1 2, testing 1 2, testing 1 2. All right, hypocalcemia. We're talking about a serum blood level below 8.5 milligrams. Definitely hypocalcemia can be life-threatening due to the effects on the cardiovascular and respiratory systems. The three most common etiologies of hypocalcemia today are a lack of intake of calcium, a lack of intake of vitamin D, and the development of chronic renal failure. Other causes may include frequent transfusions of citrated whole blood, prolonged bed rest, respiratory or metabolic alkalosis, parathyroidectomy, and pancreatitis. Clinical manifestations of hypocalcemia may include such things as tetany, and that tetany may develop in the larynx, seizures, abdominal cramps, diarrhea, bradycardia, osteoporosis, paresthesia of the fingers and toes and subcortical region, as well as bleeding. We may see a positive Chavostex and Trousseau signs as well. Treatment is calcium gluconate versus calcium chloride, which is much more irritating to the tissue. If the patient is taking digoxin, the nurse needs to be cognizant of the fact that hypocalcemia can potentiate the effects of dig. With any drug that's given intravenously, the RN should always check the IV site for patency to assure All right, hypocalcemia. We're talking about a serum blood level below 8.5 milligrams. Definitely hypocalcemia can be life-threatening because of the effects on the cardiovascular and respiratory systems. The three most common causes of hypocalcemia today are a lack of intake of calcium, a lack of intake of vitamin D, and the development of chronic renal failure. Other causes may include frequent transfusion of whole citrated blood, parathyroidectomy, prolonged bed rest, and metabolic or respiratory alkalosis. Clinical manifestations may include tetany, and that tetany may develop in the larynx. We may see laryngeal spasms, abdominal cramps, diarrhea, bradycardia, an increase in the DTRs, confusion, numbness of the fingers and toes and mouth, bleeding, bradycardia, and osteoporosis may be clinical manifestations. Treatment may include the administration of calcium gluconate intravenously versus calcium chloride, which is more irritating to the tissue. If the patient is taking DIG concurrently with hypocalcemia, the RN should be aware that hypocalcemia potentiates the effects of DIG. IV patency should be assessed before the administration of IV calcium gluconate. The IV solution of choice is D5W versus 0.9% normal saline. There is a quality and safety nursing alert on page 260 regarding calcium administration. In the past, we've discussed why chronic renal failure is a risk factor for hypocalcemia. Treatment for hypocalcemia includes seizure precautions. The RN should be aware of nursing interventions that should be instituted in someone who is at high risk for seizures. We want to monitor the airway. Again, hypocalcemia can increase the risk of laryngeal spasms. A trach set should be at the bedside. Vitamin D may be prescribed for a patient with hypocalcemia. Vitamin D increases the absorption of calcium in the GI tract. Certain antacids, such as aluminum hydroxide, increase the excretion of phosphorus, and in turn, we can see better absorption of calcium. These antacids would be given prior to any calcium replacement. The recommended intake of calcium per day is 1,000 to 1,500 milligrams. Foods such as milk, green leafy vegetables, canned salmon, sardines are high in calcium. If the patient takes calcium supplements, they should be taken in divided doses and should be taken with meals for better absorption. Calcium absorption is inhibited by caffeine, alcohol, certain antacids such as Tums. The patient should be made aware to avoid these things while taking calcium supplements. Cigarette smoking also increases the urinary excretion of calcium. Hypercalcemia, just like hypocalcemia, can be life-threatening. When we're talking about hypercalcemia, we're talking about a calcium level above 10.5 in the ECF. Excess calcium decreases neuromuscular activity, particularly in smooth and striated muscle. Clinical manifestations may include bone pain, muscle weakness, incoordination, abdominal pain, dysrhythmias, constipation, and nausea vomiting. Causes of hypercalcemia are malignancies, hyperparathyroidism, excess vitamin D intake, excess use of calcium supplements, and prolonged immobility. Treatment: 0.9% normal saline, may be used. All right, hypercalcemia. We're talking about a serum blood level above 10.5. Just like hypocalcemia, hypercalcemia can be life-threatening. Why is that so? It's because excess calcium decreases neuromuscular activity, particularly in smooth and striated muscle. Clinical manifestations of hypercalcemia may include such things as dysrhythmias, muscle weakness, bone pain, incoordination, nausea, vomiting, anorexia, and constipation. Causes of hypercalcemia may include such things as malignancies, hyperparathyroidism, excess intake of vitamin D, excess intake of calcium supplements, multiple fractures, and prolonged immobility. Treatment for hypercalcemia: 0.9% normal saline may be ordered. It dilutes calcium and promotes the excretion of calcium from the kidney. Meds such as furosemide, which is a loop diuretic, biphosphonates like alendronate or Fosamax, IM calcitonin may be given to decrease calcium levels. Obviously, we're going to teach the patient to decrease the intake of foods high in calcium. We want the patient to ambulate as much as possible. We want to encourage oral fluids, 3 to 4 quarts per day. Oral fluids that contain sodium aid in the excretion of calcium. But again, these fluids may be contraindicated if the patient has any signs of fluid overload or hypernatremia. Magnesium. Normal serum magnesium levels range between 1.3 to 2.3 milligrams. Magnesium is important in maintaining neuromuscular function. A key thing to remember about magnesium: magnesium affects excitability and contractility of nerves and muscles. Too little magnesium, we see excitability and an increase in contractility. Too much magnesium, we see an increase. No, too little, excitability. Magnesium is a cation, and serum blood levels range between 1.3 to 2.3 milligrams. Magnesium is important in maintaining neuromuscular function. Too little magnesium, we see excitability and increased contractility. Too much magnesium, we see a decrease in excitability of neuromuscular activity and a decrease in contractility. Magnesium produces vasodilation and decreases PVR. 2/3 of magnesium is free in the blood and unbound to albumin. Generally, as magnesium levels change, so do calcium in the same direction. Causes of hypocalcemia. Causes of hypomagnesemia may include alcoholism. It is the #1 cause of hypomagnesemia, followed by GI losses. NG suctioning, diarrhea may be causes of hypomagnesemia. Most MEG is reabsorbed in the distal ileum. People who are receiving prolonged enteral or parental feedings may be deficient in magnesium. Magnesium may be added to TPN to prevent hypomagnesemia in people who are NPO or people who have prolonged diarrhea. Manifestations: neuromuscular irritability, excitability is increased. We can see positive Chvostek's and positive Trousseau signs. Muscle weakness, tremors, dysrhythmias, alteration in mood, such as depression, seizures, and dysphagia. Medical management may include the administration of oral magnesium. As I said, magnesium may be added to TPN. The physician may prescribe MEG sulfate. The RN should have calcium gluconate on hand to treat hypocalcemia or hypermagnesemia that may develop with excess administration of MEG sulfate. Keep in mind, if magnesium levels are low, generally so is calcium. Let's talk a little bit about magnesium before we talk about magnesium imbalances. Normal serum blood level of magnesium is 1.3 to 2.3 milligrams. It is a primary intercellular cation. It's needed for protein synthesis, energy production. It provides structure to the bone. It's needed for synthesis of the DNA. It's also needed to transport calcium and potassium across the cell membrane. So it's very important in nerve impulse conduction. It affects muscle contraction and heart rhythm. Less than 1% of the total body magnesium is found in the blood. Over half of magnesium is found in the bones, followed by the soft tissue. Serum mag levels are primarily regulated via the kidney. If levels begin to fall, the kidneys prevent the excretion of magnesium and conserve it. Mag acts on the myoneural junction, that junction between efferent nerve fiber and a muscle fiber. Imbalances affects neuromuscular activity and cardiac contractility. Too much mag, we have a decreased excitability of muscle cells. Too little mag, we have an increased excitability of muscle cells, as well as increased nerve impulse transmission. Mag may be used to prevent or control convulsions by blocking neuromuscular transmission and decreasing the amount of acetylcholine. Mag has a depressive effect on the CNS. Mag also vasodilates and decreases PVR. As I said, it can be used as an anticonvulsant. It's been shown that people with Alzheimer's disease have lower levels of magnesium. Mag may also be used as a laxative. Mag citrate, magnesium hydroxide are laxatives that may be prescribed for patients. The RDA of mag is 310 to 400 milligrams for adults. Foods that are high in magnesium are green leafy vegetables such as spinach. Nuts have the highest percentage of magnesium, with almonds being number 1. Spinach is a second great source of magnesium. Spinach has approximately 78 milligrams of mag. Nuts have approximately 80 milligrams of mag. Whole grains, cereals such as shredded wheat is another great source of magnesium, approximately 60 milligrams. Carrots, apples have the lowest levels of mag. Hypomagnesemia is pretty rare because, as I said, as magnesium levels fall, the kidneys tend to conserve it. The number 1 cause of hypomagnesemia is alcoholism, followed by diarrhea and intestinal fistulas. Most dietary mag is absorbed in the ileum. So Crohn's disease may be another cause of hypomagnesemia. We can also see hypomagnesemia on people who are in PO for a prolonged period of time and their enteral or parenteral feedings are lacking magnesium. Magnesium may be easily added to TPN when ordered by the physician. Clinical manifestations of hypomagnesemia may include neuromuscular irritability. When mag levels fall, so do calcium levels. So we can see a positive Chavostex and Trousseau sign, tremors, dysrhythmias, alterations in mood such as depression, apathy, seizures, and dysphagia can all be manifestations of hypomagnesemia. It's also been shown that people who have migraines have lower levels of magnesium. Medical management may include ordering magnesium for people who are receiving TPN, the administration of mag sulfate, increase in the diet in foods that are high in magnesium. One electrolyte you probably haven't heard too much about or seen in abnormal levels in the clinical area is magnesium. Magnesium is a very important intracellular cation, and it has a number of roles in the body. It's needed for protein synthesis, energy production. It provides bone structure. It's needed for synthesis of the DNA. It's needed to transport calcium and potassium across a cell membrane. In fact, you should remember, as magnesium levels change, so do calcium and potassium levels in the same direction. It's important in nerve impulse conduction, muscle contraction, and maintaining normal heart rhythm. Over half of magnesium in the body is found in the bones, followed by the soft tissue. Less than 1% of total magnesium found in the body is in the serum. Magnesium is solely excreted via the kidneys. If magnesium levels begin to fall, the kidneys will conserve magnesium. Magnesium acts on the myoneural junction. That's the junction between an efferent nerve fiber and a muscle fiber. Too much magnesium, we have decreased excitability of muscle cells. Too little magnesium, we have an increased excitability of muscle cells. Magnesium causes vasodilation and decreases the PVR. Magnesium may be used to control seizures by blocking neuromuscular transmission and decreasing levels of acetylcholine. Magnesium has a depressant effect on the central nervous system. It has been shown that patients with Alzheimer's disease have lower levels of magnesium. Magnesium may also be used as a laxative in such drugs as mag citrate and mag hydroxide. The RDA is 310 to 400 milligrams in adults. Foods high in magnesium, number one, is nuts. Almonds have the highest level of magnesium at 80 milligrams per ounce, followed by spinach at 78 milligrams per half cup. Whole grains, cereals such as shredded wheat are another good source of magnesium, containing 60 milligrams. Carrots and apples have the lowest concentration of magnesium, approximately 10 milligrams each. Hypomagnesemia is fairly rare because, as I said, as magnesium levels begin to fall, the kidney conserves it. The two primary causes of hypomagnesemia are chronic alcoholism followed by diarrhea and intestinal fistulas. Magnesium is absorbed in the ileum. Other causes of hypomagnesemia are low intake as well as prolonged GI suction. It's been shown that people who have lower GI diseases, such as Crohn's disease, chronic diarrhea, have a higher risk for hypomagnesemia than those who have upper GI losses, such as vomiting. Clinical manifestations of hypomagnesemia may include such things as loss of appetite, dysrhythmias, and those dysrhythmias can also occur because of concomitant low levels of calcium and potassium, tremors, positive Chifostex and Trousseau sign, muscle weakness, alterations in mood such as apathy, depression, seizures, and dysphagia may all be clinical manifestations of hypomagnesemia. It's also been shown that people with migraines have lower levels of magnesium, but it has not been shown that magnesium supplementation in people with migraines is effective. Nursing management may include such things as patient teaching related to a diet that would be high in magnesium, such as green leafy vegetables, nuts, seafood, whole grains. Teach the patient to avoid the use of alcohol, which decreases the absorption of Meg. The nurse should be aware that IV Meg sulfate, if given too rapidly, may cause asystole. As I said earlier, hypomagnesemia is most often accompanied by hypocalcemia. Low Meg may cause dysphagia, and we want to assess for the presence of dysphagia before we administer food or fluid to the client. Nursing management may include such things as patient teaching relating to a diet that is high in magnesium, such as green leafy vegetables, nuts, seafood, whole grains, ensuring patient safety. Remember, guys, this patient is at higher risk for seizures, so they should be on seizure precautions. Again, when magnesium levels are low, generally so are calcium levels. The nurse wants to teach the patient to avoid alcohol. Alcohol decreases the absorption of Meg in the GI tract. We want to teach the patient to avoid medications that may inhibit Meg absorption, such as medications that contain calcium. I don't know about that one. Nursing management for hypomagnesemia may include such things as patient teaching regarding the diet for foods that are high in magnesium, such as green leafy vegetables, nuts, seafood, whole grains. Teaching the patient to avoid the use of alcohol, which inhibits the absorption of Meg in the GI tract. Ensuring patient safety. Remember, guys, that as magnesium levels fall, so do calcium levels. Patient is at higher risk for seizures. Hypomagnesemia may be a cause of dysphagia. The nurse needs to assess the patient prior to the administration of any oral liquids or foods for the presence of dysphagia. The nurse should also be aware that IV meg sulfate may be prescribed to this patient, and if it's given too rapidly, it may cause asystole. Nursing management includes patient teaching, again, in regard to diet of foods high in meg, ensuring patient safety. Remember, these patients are at higher risk for seizures. Teaching the patient to avoid alcohol intake. Administration of IV magnesium. IV meg should not be administered more than 150 milligrams per minute at a time. Too rapidly administration of magnesium may cause asystole. Meg can also be given IM, 1 gram every 6 hours in a 24-hour period. Since dysphagia may occur in patients who have hypomagnesemia, the RN should assess for the presence of dysphagia prior to the administration of any food or fluid to the client. Nursing management for patients who have hypomagnesemia includes such things as assessing patients who are at high risk for hypomagnesemia, such as people with chronic alcoholism, people with Crohn's disease, people with prolonged diarrhea. Ensure safety. Again, these people are at high risk for seizures, so the RN should be aware of the need for implementing seizure precautions. Teaching patients to consume foods high in magnesium, which I've already addressed. Teaching patients to avoid alcohol use. Teaching patients to monitor for signs and symptoms that magnesium levels are improving. Assessing patients for the presence of dysphagia prior to the administration of any food or fluid, because low magnesium may be a cause of dysphagia. Magnesium may be added to TPN by the physician. We can give magnesium intravenously, 4 grams in 250 d/w, to be administered no rapidly than 3 mils per minute. Too rapid administration of magnesium may cause cardiac arrest. The antidote for magnesium is calcium gluconate. When giving magnesium intravenously via an IV solution, an infusion pump must be used. When giving magnesium to patients, we must assess kidney function, because remember, magnesium is solely excreted via the kidneys. Adverse effects of magnesium supplementation include flushing, sweating, hypotension, depressed deep tendon reflexes, cardiac and respiratory depression, and ultimately respiratory paralysis. Magnesium may also be given IM. It's given deep into a muscle. It can be given 1 gram every 6 hours within a 24-hour period. All right, let's look at treatment for hypomagnesemia. Obviously, we want to be monitoring patients who are at high risk. Those with chronic alcoholism, those who have chronic diarrhea, those who have Crohn's disease. Calcium levels will be low, as we've said before, so the patient's high risk for seizures. So the RN needs to institute seizure precautions in these patients. We want to teach the patient to consume foods high in magnesium, of which we already talked about. The physician may order IV meg sulfate 4 grams and 250 cc's of D5W to be administered at 3 milliliters per minute maximum rate. Mag may also be added to TPN. Again, we want to be cautious in giving magnesium to patients who have renal failure. If mag is given too rapidly, it can cause cardiac arrest. The antidote for mag sulfate is calcium gluconate. As with all medications that are given intravenously, we want to assess the IV site for patency and administer the IV solution via an infusion pump. Mag may also be given intramuscularly, 1 gram IM, deep within a muscle every 6 hours in a 24-hour period. Mag sulfate is discussed in Chapter 30, page 235 of the ATI Pharmacology book. Too much mag may be manifested as sweating, excessive flushing, hypotension, depressed DTRs, and can lead to respiratory and cardiac arrest. Hypermagnesemia. Hypermagnesemia is characterized by a serum blood level greater than 2.3 milligrams. It is an electrolyte imbalance that occurs very, very rarely because the kidneys are very efficient in regulating magnesium levels in the body. As that being the case, the number one cause of hypermagnesemia. We're talking about a serum blood level greater than 2.3 milligrams. Hypermagnesemia is a pretty rare condition. Why is that so? It's because the kidneys are very effective in aiding the regulation of magnesium. With that being said, obviously then the number one cause of hypermagnesemia would be chronic renal failure. We can also see hypermagnesemia with excessive administration of magnesium. As you'll learn next semester, mag sulfate may be given during pregnancy to prevent or treat seizures that may occur during pregnancy. Excessive use of magnesium antacids such as Maalox, Mylanta, may also be another cause of hypermagnesemia. As magnesium levels elevate, the CNS is depressed as well as neuromuscular activity. When mag levels are high, so are calcium levels. Manifestations of hypermagnesemia: hypotension, hypoactive reflexes, muscle weakness, decreased respirations, decreased heart rate, bradycardia, cardiac arrest. So as you can see, it can be very, very serious. Medical management includes IV calcium gluconate, loop diuretics, IV normal saline or RL, and/or hemodialysis. Obviously, we want to teach the patient not to take in substances that contain magnesium to avoid over-the-counter medications such as Maalox and Mylanta. We want to be aware that any patient we care for who has renal disease is at risk for hypermagnesemia. Hypermagnesemia, characterized by a serum blood level greater than 2.3 milligrams. It's a fairly rare electrolyte imbalance, but it sure can be seen in people who have chronic renal failure. Again, remember, the kidneys are the primary organ or sole organ for magnesium excretion. Hypermagnesemia can be also related to excess administration via TPN, the use of antacids such as Maalox and Mylanta that contain magnesium. It can be seen with DKA, soft tissue injury, and trauma. When magnesium levels elevate, we see depression of the CNS. And the first clinical manifestations to be noted in hypermagnesiemia are a decrease in the DTRs. As magnesium levels continue to elevate, the DTRs, the deep tendon reflexes, will disappear. As magnesium levels continue to elevate, respiratory distress will develop, followed by cardiac arrhythmias, which can be fatal. Clinical manifestations of hypermagnesiemia, as I just said, first appear in the deep tendon reflexes. Remember, magnesium promotes vasodilation, so we can see a decreased blood pressure, hypotension. We can see flushing, excessive sweating, drowsiness, skeletal muscle weakness. IV calcium gluconate counteracts the effect of magnesium. It is considered the antidote for magnesium toxicity. Loop diuretics promote the excretion of magnesium in people who have normal renal function. The use of 0.9% normal saline, as well as lactated ringers, may also be used to promote the excretion of magnesium via the kidneys. And people who have chronic renal failure, hemodialysis may be a medical management. Obviously, we're going to teach the patient to avoid foods that are high in magnesium, which have already been discussed. We do not want to administer medications that contain magnesium, such as Maalox, Mylanta. We want to teach the patient to avoid taking these drugs without notifying the physician. All right, let's look at hypermagnesiemia, characterized by a serum blood level greater than 2.3 milligrams per deciliter, a fairly rare electrolyte imbalance in people who have normal renal function. As we said, the kidneys are solely responsible for the excretion of magnesium. So as magnesium levels would rise, the kidneys would increase excretion of this electrolyte. As a result, the number one cause of hypermagnesiemia then would be chronic renal failure. We could also see hypermagnesiemia in people who consume excess amount of antacids that contain magnesium, such as Mylanta, Maalox, milk of mag. Excess administration of magnesium via TPN therapy or use of magnesium sulfate as an anticonvulsant to control seizures can also be another cause of hypermagnesiemia. People who suffer soft tissue injuries with motor vehicle trauma can also have elevated levels of magnesium. Clinical manifestations: the deep tendon reflexes decrease with hypermagnesiemia. In fact, a change in the DTRs is often the first clinical manifestation noted as magnesium levels begin to rise. As magnesium levels continue to rise, the DTRs, the deep tendon reflexes, will no longer be present. Magnesium causes vasodilation, so with elevated levels, we see sweating, flushed skin, and a lowering of the blood pressure. We can see drowsiness, muscle weakness, a depressed respiratory and cardiac function, and ultimately cardiac and respiratory arrest. Management includes IV calcium gluconate, which is the antidote to MEG intoxication, the use of loop diuretics, the use of IV normal saline or Ringer's lactate. They promote the excretion of magnesium via the kidney in people who have normal renal function. People who have chronic renal failure, dialysis may be a medical management in decreasing levels of magnesium. We want to teach the patient to avoid consuming antacids that are high in magnesium, as well as foods that are high in magnesium. Phosphorus is a critical component of all body tissues. It's essential to the function of muscle and red blood cells. It is critical for the formation of ATP and for 2,3-diphosphoglycerate, which is a component found in the hemoglobin molecule that regulates the release of oxygen to the tissue. It's important in the maintenance of normal acid-base balance. It can pick up or release a hydrogen ion. It is important for the metabolism of carbohydrates, fats, and proteins. It provides structural support to bones and teeth. 85% of the total body phosphorus is found in the bones and teeth. It is a primary intracellular anion. 1% of the total body phosphorus is found in the serum. Normal serum levels are 2.5 to 4.5 milligrams. Foods high in phosphorus include dairy products, whole grain cereals, nuts, meats, and colas. Phosphorus is primarily excreted via the urine as well as the feces. Hypophosphatemia may be due to chronic alcoholism. Can also occur due to sudden administration of carbohydrates to patients who have been malnourished or starvation diets for a prolonged period of time. The increase in carbohydrate calories promotes a shifting of phosphorus into the cells out of the blood. Low phosphorus can also be due to a lack of intake, diuresis, diarrhea, vitamin deficiency, and the prolonged use of phosphorus-binding antacids such as TUMS. The clinical manifestations of low phosphorus are related primarily due to a lack of ATP as well as a lack of oxygen at the tissue site. So hypoxia, paresthesia, pallor, muscle weakness, tachypnea may all be manifestations of hypophosphatemia. Hypophosphatemia increases the risk for infections because of a lack of ATP within the granulocyte. The granulocyte cannot perform one of its primary roles, and that is phagocytosis. Medical management is the administration of IV phosphorus either orally or intravenously. We can add phosphorus to TPN, enteral feedings. We can give phosphorus IV in the form of sodium or potassium phosphate. Phosphorus can also be administered orally in the form of NutraPhos capsules. NutraPhos capsules are indicated for hypophosphatemia as long as there is normal kidney function. NutraPhos capsules come either in a tablet form or a powder form. If they're in a powder form, the powder should be mixed with 1/3 cup of water and consumed immediately. Ideally, PO phosphorus as well as NutraPhos is taken with meals. Patients should be taught to avoid calcium products while they're taking phosphorus supplements, because calcium products would decrease phosphorus levels. The nurse needs to institute measures to prevent infection. Again, the patient is at higher risk for infections. Encourage foods that are high in phosphorus, such as milk, milk products, fish, and poultry. And teach the patient to avoid phosphate binding antacids, such as Tums. Hyperphosphatemia, characterized by a serum blood level greater than 4.5 milligrams per deciliter. The number one cause is chronic renal failure. Other causes may include excess intake of phosphorus, as well as hypoparathyroidism. Keep in mind when phosphate levels are high, calcium levels are low, and many of the clinical manifestations associated with hyperphosphatemia occur as a result of hypocalcemia, such as tetany, hyperactive reflexes, soft tissue calcifications. Medical management is focused on treating the underlying disorder, administering vitamin D preparations such as calcitrol, administering phosphate-binding gels or antacids such as sevelamer, Amphigel, milk of Meg, all which bind phosphate in the intestines and promotes excretion via the feces. Loop diuretics, IV normal saline, promote the excretion of phosphorus from the kidneys. In severe elevation, dialysis may be employed as a management tool. Nursing management includes obviously assessing patients who are at high risk for hyperphosphatemia, particularly those with chronic renal failure. Teaching patients to avoid foods high in phosphorus, such as dairy products, whole grain cereals. Teaching patients to avoid phosphate-containing substances, such as biscuitol, Fleet's phosphoenemas, and teaching patients to be aware of signs of hypocalcemia.